Thanks again for the invitation. I hope you had a nice coffee break. So we continue with infectious diseases, spondylodiscitis, anterior versus posterior approach. Structure of my presentation, what kind of indications we have for surgery, what possible procedures, decompression alone, stabilization, minimal invasive stabilization, or anterior approach, and then at the end I will say a few sentences about aftercare. So, indications for surgery in infectious diseases, I think one is the epidural abscess. You can have it monosegmental as seen in this case, or here you have a chunky addicted to drugs with multi-level spondylodiscitis. Here you can see 1, 2, 3, 4 levels, and here the epidural abscess. In this case is, of course, you have to do surgery. Another indications are septic diseases. If you have a septic patient in the intensive care unit, you have to do surgery. This is a patient with immunosuppression, lymphoma, and this spondylodiscitis T6-7. And if you look here, you can see the epidural abscess from L1 up to the occiput, and there is another abscess in the muscles at C1. So, of course, these are indications for surgery. Another indication, of course, are the neurological deficits. This is a patient who came to me in the year 2040. You can see here this spondylodiscitis T10 and 11, and no epidural abscess, and the patient says, "Oh no, doctor, no surgery for me, please." So I said, "Oh, okay, we can wait." 1 month later, you have a changed situation. You have here a kyphosis, a collapse of the vertebra, and you see you have a progressive disease. And now I told him, now we should do surgery. But again, he said, "Oh no, I don't want to have any kind of surgery." So we did another control 1 month later. Now you can see you have myelopathy with paraplegia, partial, and in this case, of course, we had to do surgery 1 month earlier. And therefore, another indication is instability. You can only treat a spondylodiscitis in a stable situation. What kind of possible procedures we have? You can do a decompression only without stabilization in an isolated abscess, but I don't like this procedure very much. I think it's a rare indication, because it's only possible if you have no involvement of the discs and the ligaments. So maybe it's sometimes an indication in emergency cases. Standard procedure in our department is dorsal stabilization with removal of the disc space and cage interposition. Here, this is a patient which is 52 years old with sepsis. He has aortic valve insufficiency, and the cardiac surgeons did a replacement of the valve, and he has this spondylodiscitis with this epidural contrast agent enhancement. So, of course, I did a stabilization with cage interposition. How do I do it in detail? I normally do an open approach, screw placement in my clinic freehand technique. Then I do the tail lift procedure with a titanium cage, open up the foramen, mobilize the nerve, and then you can open up the intervertebral disc space. Here you see the cage. I think it's very important to add some antibiotics in the disc compartment. I usually take a gentamicin, and you have to rinse with an antiseptic agent, Lavanit or Pronol, whatever you have in your clinic. Indications for anterior approach, of course, if you have an extended bony defect, as you can see here in this site is T11-12. Here's the CT scan where you can see the same lesion. You have to do a posterior stabilization and then a ventral vertebral body replacement. And I additionally did here some rib interposition for long-term stability. Another indication for anterior approach, I think, if you have espondilodiscite, as you see here, you have no involvement of the spinal canal, it's completely free. So I don't want to have any bacteria in the spinal canal, so I do a dorsal stabilization and then an A-lift procedure from an anterior approach. Another indication is a percutaneous stabilization. If you have a patient with a high operative risk, you can do minimal invasive surgery without disc removement and just do a stabilization and the antibiotic therapy. As you can see here, 3 months after stabilization without disc removement, you have a stable situation and the patient is happy without large surgery. But in these cases, you should be very careful, because another case I want to show you, which was operated in another hospital, you have a 42-year-old female patient with chronic back pain. She's addicted to drugs, has a hepatitis, and they did surgery without cage interposition, without removement of the disc, just stabilization, and then they did not do regular X-ray controls, and 2 months later here was the problem. You see a collapse of the fifth lumbar vertebra, you see a screw loosening and a loss of reduction. So they did a large revision. They put another screws in L4 and dorsal-ventral-dorsal approach. And here you see the cage in L5-S1 and another cage in L4-5. And this was the presentation in my clinic. Unbearable back pain, patient can only walk with a walker and she can hardly stand without support. You see the problem here, you have a hypolordosis, you have reduced bone quality because of this infection, you have bad soft tissue, patient continue to use drugs, and of course you have this hypolordosis because the stabilization came too late. Here you have a bony fusion, but in this hypolordosis was 24 degrees. So at the end you only can do large surgery. Here in this case I had to do a osteotomy of L3. You have to do this ilium screws to get a strong hold and to have a patient which can stand in a straight position. So if you do surgery without cage interposition, you have to do X-ray controls in regular periods. Another topic you have to mention about spondylodiscitis, I think, is the psoas abscess. If you do an anterior approach, of course, you can remove the abscess in a direct way. Another possibility is to insert a drainage CT controlled, as you can see here. And the third possibility, which I prefer if it works, is the drainage insertion through the disc compartment, as you can see here. Here you see the T-lift. There was a hole in the compartment, and then with a small instrument you can open up it a little bit and put in the drainage like this, and then you can insert this without CT scan or with large anterior approach. So I think these are the possibilities you have with the smaller abscesses. You can treat conservative if they are only 2 or 3 centimeters, but I think the larger one should be addressed. Then something about the aftercare. I think it's important to give antibiotics, of course. We do it parenteral for 2 weeks, and then we want to see a decrease of the infectious parameters in blood. If they persist, we do parenteral antibiotics for 4 weeks. Then we add oral therapy for 3 months. Long period, but I think it's necessary. Some other studies said 6 weeks are okay, but I think in these cases you have to take a safe way. And then another important point in spondylodiscitis is you have to find the bacteria. Sometimes it's not possible, but it's very, very important that you take blood cultures out of the patient before you start with antibiotic therapy. You should do this blood culture before surgery, long time before surgery, and always do it before you start antibiotic therapy, because it's the best and the easiest way to find out what bacteria you have. And then what kind of antibiotics you use. There is no standard recommendation in the literature. In our clinic we use clindamycin or linezolid if we have a methicillin-resistant Staphylococcus aureus. So I think if you do it with this aftercare and with the surgery I explained, you can handle spondylodiscitis in a good way. Thank you very much for your attention.